Welcome and thanks for joining today's webinar on the PMT Halo System. So in a moment, I'll pass over to Mackenzie, who is the Vice President at PMT Corporation, and Ray Walker, who is the National Sales Manager. They'll take you through the PMT Halo System, key features, benefits, applications, adjustments, and so forth.
Awesome. Thanks, Bill. So my name is Mackenzie Iverson. I'm the Vice President here at PMT Corporation. I've been with PMT for just over 6 years, and I've actually been working with Massons for almost 5 now. I started with marketing here at PMT, transitioned into international, being able to work with our amazing distributors like Massons. And throughout that whole process, Ray Walker and I have had the joy of giving some awesome Halo trainings, do some group webinars like this, one-on-one. So we're really looking forward to spending some time going through the Halo with you. Ray, you want to give your background?
Yeah, thank you, Mackenzie, and thank you, Bill and Phil, being the fly on the wall. I appreciate you having us today. This is my second opportunity to do this type of training with you all and your accounts across the country, and it's very exciting, and I appreciate the opportunity. I've been with PMT a total of 23 years, and I've had great experience doing halos from a clinical standpoint, from a training standpoint, probably well over 500 or 600 patients. We will definitely hit all of the top key components, features, benefits of the Halo while we go through our PowerPoint. I think that as you go through the entirety of the training, we ask the questions at the end because Halo is pretty dicey, and I think we'll hit your questions maybe even before the end. So I think it's a good advantage that we wait till the end to do those questions, but I'm so glad to be here and so appreciative to help you all with our Halo system.
So I'll get started just on the way of, I think for those of you who have worked with the Halo before or who have been a part of a training before, some of this might not be brand new information, but hopefully throughout this process, you'll be able to learn something new. To get started, a brief overview of the Halo system for PMT. Ours was developed with the goal to have quality MR and CT capabilities, while also being able to be applied in a manner that was easy and fast, but still a rigid external fixation. So with our system, we'll go through this in even further detail, but because of the design of our head blocks, because of the design of the, even just the chest blocks with the nylon balls, throughout this process and throughout this presentation, hopefully it shows a little bit more about the ease of application and what makes this a really user-friendly Halo system. So we'll go through some of the fixtures that make the Halo system 1.5 and 3 Tesla conditional. But really, we're going to hopefully touch on everything that answers your questions, like Ray said, and gives you and everyone on this presentation a little bit more confidence and really solid understanding of the Halo system from PMT. So getting started, Ray, do you want to talk a little bit about the MR imaging difference?
Sure. So one thing I did quickly want to add to Mackenzie, she said rigid. That is the key component of a Halo. It has to be rigid. The competitors out there that are still in place, most have shipped, but rigidity is the key. It has to be like a cast, and PMT's is the most rigid by far. What makes PMT a MRI compatible device is the materials that go into the construction and manufacturing the product. Titanium, platinum, acrylic, graphite, all of these things are non-ferrous materials that are going to allow you to go through the MRI CT. The reason why diagnostically the advantage of having a MRI CT compatible device is that they get a very good idea of the location of the skull in the skull post application. They have an opportunity to view the cervical spine of those scans, and it'll give them a greater opportunity to see the actual alignment, not just from an X-ray, which can have some shadow, but MRI and CT provides them, okay, is there any vascular situations with the CT? No. Okay, are we okay with the cervical alignment? Well, this looks okay, but we need to do a little bit of an adjustment. And the great thing, Mackenzie mentioned, the head blocks. The head blocks, you can make all the adjustments while the patient maintains being fixated. You don't have to take them out of traction to make the adjustment. That we're the only one that has that, and that is a huge benefit. So one thing I will mention, it's key. A patient might say to the radiologist doing the MR, hey, I feel a heating sensation at a pin site. It's not heat, it's vibration. That means the skull pin is loose. So what they want to do is they want to make sure that they unloosen the locking nut, make sure it's at 8 inch-pounds, retorque that locking nut, and they can go on about their business, and there will not be vibrations, which they think is a heating sensation. So I hope that information helps.
As far as the vest and the liner goes, Masson's offers both of our liner options. So we have the traditional lamb's wool liner. So that's what you think of when you think of the traditional Halo. It's comfortable, it's very, very soft. And we also offer Coolmax, which is a wicking material. So sometimes a little nicer for warmer climates, or if you are a patient that is maybe particularly sweaty. That's going to be a little bit more comfortable for them versus something like this because it is so thick and it does hold that heat in a little bit more. As far as the vest itself, what's really great about the vest is when it comes to the design of the shell, we have different options. So the most common option is going to be, we'll talk about this a little further, the 1233, which has a really nice soft shoulder. But you can also do a more rigid shoulder where the shell comes up and over. The pediatrics are a little bit more comprehensive. The shell comes up and over. So you can do an airbag. There are a lot of options to be able to fit your patient needs. And that starts with making sure that we have the best liner material so that they are comfortable during that process. And they can be changed. So in case a patient gets sick, or in case, again, if they are sweating through the liners, these can be changed while still having been applied to the patient. Ray, I don't know if you want to comment on that at all.
Yeah, at the end, if you would like for me to review the pillowcase technique for liner changes, I'll be glad to do that. It's a very simple process that I'll go through at the end.
Perfect. Thank you. So these are the two up-close pictures of the liners. So on the left-hand side, what you see there is a pediatric vest with the lamb's wool liner. On the right-hand side, you see the adult with the Coolmax liner. So the Coolmax, you can see it's more of a, it almost has an athletic look to it. So that's going to be able to wick the moisture away. It's traditionally what we see being used in, again, those warmer climates. And this speaks to a little bit more about what Ray was speaking on as far as the materials. So Ray mentioned this a little bit, but we actually have an example image on the right-hand side showing a MRI of a patient wearing a PMT Halo. So this gives a good example of what that clarity and imaging can look like. And so this is an overview of the materials here. The rings, there are two types of rings. There's the open back and the closed back. They all come packaged as what's called a ring set. So you'll get your graphite ring, and then you'll come with some brass positioning pins and then titanium head pins, as well as the wrench and hex keys. So the open back rings, those are what's shown here on the right-hand side. It has a opening at the back of the ring. And the closed back ring is a full loop of the graphite. So there's no interruption in that design. The open back and closed back rings can be used for different reasoning. The open back ring is going to be the most popular. So globally, it tends to be the preferred option. However, closed back rings can be the preference when it comes to pediatric or elderly patients. And the reason for that is there is a difference in the skull density. So when you have a lower skull density, you might not want to do a traditional pin placement, which is only 4 pins. You might need to do more pins, and that's just because of the bone density. That's going to be patient to patient. But because the closed back ring is the full circle, you have more pin placement options to be able to provide that stability. And then the images here show an example of what the skull pin looks like. So with the small, medium, large, and so on, they come with 5 skull pins and 3 positioning pins. With the extra small and extra, extra small, because those are typically pediatric use, they do come with 2 times the pin sets, with the assumption that being a pediatric patient, you'll need some more skin skull pin placements. Ray, anything to add with the rings or the options there?
Yeah, so in addition to pediatric and the elderly patients with comorbidities, PMT does recommend a closed back ring with extra pin sites. Patients with osteo, there's different reasonings behind it. And a doctor may have a preference period. And so we want to make sure we adhere to their needs. There is one thing about our skull pin. It's considered a parabolic skull pin. So once it is screwed into the skull, it's an arrow tip. It kind of has a pronounced tip to it that's kind of like an arrow, and then it's got a flange that it kind of reduces down and then goes out, and that's what seeds that skull pin into the skull very, very strong. And so the design does 2 things. It seeds into the skull and bone very well, and it reduces the risk of potentially penetrating the skull and going into the brain. So that is something, if you have questions on, we can address those at the end.
Mm-hmm. The head blocks, these are small but mighty. The design of these is something that we're incredibly, incredibly proud of. So the head blocks, you have different sizes. You have your standard, which is your 120620. You have an extra long, which is a 120632. And then you have an extra, extra long, which is a 120633. For pediatric or smaller vest sizes, the most common is going to be the 120620. If you get into the medium-sized vests on an adult and larger, you're going to want to consider doing a 120632 because that length helps with the width of the patient body from chest to back. And then there are closed back ring head blocks that are made specific for those closed back rings because of where the head block, as you can see here, there's 2 of those screws. Because of where the head block attaches, it is slightly different. So if you're ever ordering a closed back ring, make sure that you are ordering the closed back head blocks. Just a slight difference, but the head block itself, no matter what, you have 3 different points of adjustment. So with this, you see there is it goes laterally along the head block here. B, you see this curvature, and what that comes from is these screws here. So within the head block, right here, you can see there's almost like a C shape. That is what allows it to go like this. And then lastly, it's almost hidden at the top of each head block. You can place an Allen wrench inside, and you can adjust to do slight adjustments moving vertically. So that's your C marker there. So the head block is where you can do a lot of adjustment in a very small area. Ray, do you want to add anything about the head blocks there?
Yeah, so I was lucky enough to start at PMT and was able to meet the engineer that designed these. His name is Bill Eastman. This is a real game changer. This is what allows the PMT Halo for you all to make clinical adjustments based on the X-ray or the MR image post application. As Mackenzie pointed out, is what is the you can make an adjustment if the fracture is kind of a little bit forward and it's lined up. You can then do an anterior posterior adjustment. So you can slide that head block forward, the ring that's attached to the head block forward, and that would be your anterior. And you move it exteriorly, that would be your posterior adjustment to align the fracture completely level with itself. B, that Mackenzie pointed out, is flexion extension. If if the top of the fracture is up, you want to get that part down. So you want to flex or extend that vertebrae to be equal. And then the number one thing is C, traction and compression. If that vertebrae is just, it's level, everything looks great, but you want to compress it down on itself, that's when you take that Allen wrench into C, and the notch above, looking above the halo, looking at the patient's head, you'll see a little screw inside that block, and you tighten it to lower it or loosen it to raise it. And this is what makes PMT a really, really special product, because they maintain their traction, but you can do the adjustments without taking them out of traction. And we can address questions at the end on this.
Mm-hmm. Yeah, some of this plays into application, but I mean, the head block itself is just, it's one of the coolest parts of our design. It really is. So, traction bales, we do offer two different types of traction bales. So, we have our standard traction bale, which is our 120613 or 120611. The only difference is whether or not it comes with hardware. And you can see an example picture there. It also shows a closed back ring. So that image gives you an example of what that closed back ring can look like. We also have, this one is a newer model as of, I would say about what, Ray, 2019? Somewhere around there. So, a direct mount traction bale. So this is got a different design to it. It isn't the traditional triangle. It has more of a fluid design to it. And you can see you don't need the head blocks. So with the direct mount traction bale, you can do gravity traction without using head blocks. You can use just the traction bale and directly mount that to the ring. Ray, I know you see a little bit more traction bale than we do. If you're able to share a little bit of your insight into usability there.
Sure. So if a patient goes into the hospital and they are assessed and they do have a cervical fracture, but it's a situation where they don't want to use a halo, they want to fuse the patient. The first thing they have to do is reduce the fracture. The patients, they're full of white blood cells. They have a lot of edema. They're not a candidate for surgery yet. So if you reduce the fracture by putting the ring on their head with the direct mount traction bale, that will put them in traction, and their body thinks they're being healed. So their white blood cell count will go down, their red blood cell will go back up, their vitals all look good. Now they can operate and put them under anesthesia. If they don't have the ability to do that, they're going to have to do some other form of getting that fracture reduced. The other thing I really want to point out, and what we're seeing a big utilization of in the field here in the States, is Scully. there's several papers recently released on gravity traction. It's called gravity traction on patients with scoli, and they have a big, degree of bend in their cervical spine and some thoracic. And so they'll put the patient in a ring and traction bell, and they will set up a weight pulley system, either on a walker, a wheelchair, what have you, and they will pull the weight, and their cervical spine will reduce the curve of their scoli by a significant percentage. And so that is something else that you all might want to consider an application for use in your centers. And McKinsey can, provide some of the additional information on that.
Yes, yes. So each of the traction bales does have recommended weight maximums. So if that is something that your facility is interested in taking on or adding to your repertoire, we can definitely provide that information for you. The Halo system types, there are a variety of different types that are designed, as I mentioned earlier, to provide the best option for your patient. So there are different styles of the vest. That's going to be your biggest difference. So with a what's called a 1206 Halo system, that includes a 1203 vest and a closed back ring. That vest is going to be a little bit more rigid. It's going to have the over the shoulder of the vest, and then the closed back ring is going to provide you, again, as mentioned earlier, with those additional pin sites. So as you can see, the patient type is typically going to be elderly or pediatric, or as Ray mentioned, a patient with those comorbidities. The 1211 Halo system, that utilizes the 1203 style vest as well. However, it uses the open back ring. So you're still going to get a more comprehensive vest with that shoulder style, but you're going to have an open back ring. So that opens up your patient population a little bit there. The 1223 style, which is shown here, it's a 1223A, and that A means you get the very lovely blue airbag. So this is going to be designed, it's going to be still a rigid vest, but the airbag is placed along the back of the base of the spine, and it provides a little bit more patient comfort and a little bit more support. So they can pump that blue pump there on the side, and between the shell of the vest and the liner, there is a small airbag that can push and provide a little bit more of that comfort. So this one is going to be, it's going to be that rigidity, but it's also going to have some of that built-in additional support for that lower spine. Our number one most popular, though, is going to be the 1233 Halo system. So that's the one that I have shown here. This is going to be a 1233. The shell does not come over the shoulder. The shell ends right in front of the shoulder and then in the back against the blade. And then the only thing that comes up and over the shoulder is going to be the liner. So with the liner and the strap being the only thing over the shoulder, it tends to be a little bit more comfortable having that soft shoulder. And this is going to be something that, again, has a broader patient type. So it's going to be more comfortable, but again, it does depend on your patient type. Ray, any comment, remark on the different best system types that you've seen?
Yeah, so really this is also a progression of PMT systems from beginning to today. But McKinsey highlighted a really nice word that a lot of people don't like to say because it's a halo, comfort. And we all know the only patient that's going to heal in a brace is a compliant patient. And anything you can do to increase their comfort while they're in this thing for 3 months is comfort. They're going to want to wear it. They're not going to want to mess around with it. They're not going to take, excessive risk. And the air bladder is something that really does it. Their lower back may, because everyone in a halo likes to bend forward. I don't know why that is, but they do. And sometimes their lower back might get a little stiff. And that air bladder actually does provide a comfort level, but it also provides a medicinal option to where once they blow up that air bladder, they can't bend over as much and they're straight erect. So that's another thing that you might want to consider. But we still maintain the amount of compression, whether it's the 1206 or the 1233. The compression is what is important with regard to the vest. So that is all maintained throughout these systems, but your option, your choice, your patient, your choice. And I'm glad that we have these things to offer for the patient population.
So with the adult vests, this is a very brief overview again of the highlights that we pointed out there, but it gives you more of a graphic side by side of what these might look like. So you can see here the soft shoulders of the 1233. You can see here the airbag with the 1223, and then you can see the 1203. It's a very tall shell because that goes all the way up. So you can see, as Ray mentioned, there was a progression as we evolved, maintaining that support, but comfort, trying to make this as patient comfortable as possible. With the pediatric vests, these are all going to be 1203-5. So the sizing on these, you'll see we have all the way down from a 00 ped up to a ped 4. And the pediatrics are the same. You can get them with a lamb's wool liner. You can get them with a Coolmax liner. But with these, something to keep in mind with the pediatric vests, something that is unique is, and we'll get to this a little more, you'll want to make sure that, and our team will always make sure that you get these, with every pediatric vest, you'll get what's called pediatric angle blocks. And so that's why in that photo, it might seem like those rods are going a little far out. And the reason for that is the rings, even if you do a extra small or a small ring, the rings can still be a little wider than the vest. So we'll talk a little bit more about how that helps, having the pediatric angle blocks. But the other note with the pediatric sizing is there is additional size markers on this chart that need to be taken into account. So the xiphoid circumference, the shoulder to xiphoid, the shoulder to iliac crest, the neck opening. 4 measurements that will help you identify exactly which size is going to be best for your patient. And you'll see from one to the other, the differences they're not huge. They're actually quite minimal, but when you go from a PED 00 to a PED 1, that can be a big jump. From a PED 1 to a PED 4, that's a really big jump. So especially with the kiddos, having a more refined sizing system has allowed us to provide a really well-fitting vest when it comes down to the pediatric population. And stocking, when you are looking at stocking sizes for pediatrics, that can be difficult. That can be difficult because just like every adult is different, every child from one to the other, they are growing at rapidly different rates. So this can't be done on age. It has to always be done on how your sizing is completed. So generally, you're not probably going to be able to carry every single size pediatric vest. And that's part of it. That's how it goes with all of our accounts. A PED 00, that's a really, really small child. So the rarity of that happening might not lead to something that you feel is necessary to carry. When it comes to evaluating how you need to map out your stock, the Massens team, our international division, we are happy to advise our recommendation or what we typically see for stocking. But the other thing to keep in mind is PMT does keep pediatric systems on hand 24/7. So we have these stocked. So if there is an emergent situation that happens, we can work with Massens and we can do our absolute best to get that to you in as timely a manner as possible. Ray, any comment on the pediatric sizing or anything about pediatric vests that you want to bring up?
We typically recommend a PED 0, a PED 3, and a PED 4. And one thing I want everyone to keep in mind with regard to pediatrics, it depends on the child, their age group. They're going to grow while they're in this. And you end up having to go from a PED 1 to a PED 2 or 3 during the course of the 3 months. So keep that in mind. Another thing is with rings, you always want to go with just if you're in the middle of the measurement, if you're right there in the middle, it's a small or a medium, go with the medium. Vest is conversely, if you're in the middle of the size chart, go down, make it smaller. You want that tight fitting vest, but the ring can be somewhat loose. It's a little further away from the head. So keep those two things in mind when you're doing your measurements.
And when it comes to the application, so when it comes to applying the Halo, torque drivers, got to have them on hand. So these are sold separate from the Halo system. They are a separate model number. And we offer 2 types of torque drivers. So you can see our silver option here. This is your standard torque driver, your 1201-8. And this is going to be, we recommend having at least 2 on hand. Sometimes these can go missing, and then it's a little bit of a rush. So we recommend having at least 2 in your, if you keep the stock or if you keep a ortho cart. And then we have our precision torque driver, which is the 1201-7. So you'll see the difference in these is the ability that they're designed to torque to. So the standard torques from 0 to 36 inch per pound, and the precision torques from 0 to 12 inch per pound. What makes the precision is you are able to go by the 10th of a pound, whereas with the standard you go pound to pound. So that's what makes the precision. They are only meant for application. So make sure that you are using them only when you're applying the Halo. If you are using it as part of the removal or the loosening, that can alter your calibration. Now, these are calibrated for 1 year. So the standard torque drivers are calibrated for 1 year. The precision torque drivers are for 2 years. So those are the timelines to just be aware of. We do not offer recalibration. So make sure that your team is watching when those on each of the torque drivers, it has a calibration expiration date. So make sure that you're checking on those throughout the course of holding these in your stock. Ray, any comment on the torque drivers, use of application there? I know we'll get into some of it with application, but from the torque drivers themselves.
Just very quickly, the
Yeah.
1201-8 torque driver has a reversible bit. The smaller end of the bit is the skull pin. The larger end of the bit is for the rest of the superstructure. When you're making your adjustments on the 1201-8 torque driver, the gold and silver and blue, the way you set up that torque driver, the way you adjust it and put it at its weight per square inch is gold and blue. You always use and start with the 0 on. That's what you need to look at. To adjust it, you pull down on the silver ring and hold it with your index finger and thumb with the wrench portion of it in your palm. And then as you turn the gold dial, you add the number on gold to the number on blue. So 6 and 2, 6 on the gold scale, 2 on the blue scale is 8. That's 8 inch pounds. Now on the pediatric, it goes 0.1, 0.2, 0.3. That is to give the doctor the options of how much they want to torque those skull pins in children and adults. So those are the key things that you want to think about with regard to the torque drivers.
And the other option that we also offer is the breakaway torque drivers. So this is another thing to, we recommend keeping on hand. So these are designed to allow a quick and easy application for the initial settings of skull pins. So these are, we reference it here, the Journal of Bone and Joint Surgery actually did a study on these. So what they do is you can see there is a golden piece here, and then you have a handle here. So when it hits 8" per pound of torque, the black piece splits away, breaks away from the gold. So it's a really useful piece to have on hand. And the retorquing of the pins with a regular torque driver, or say a second set of breakaway drivers after that initial 24 to 48 hours, these can be used if you're torquing to that 8" per pound. Obviously, if you're torquing not to 8" per pound, if you're going lower than that for a lower skull density patient, these are not going to be your friend. You're going to want to stick with your precision torque driver. But if it is a standard 8" per pound application of those pins, these are sold in a set of 5. And they come non-sterile. So if you place an order for these, you'll get a set of 5. And so that's designed for if you're placing the standard 4 pins, and then you get 1 extra just in case. Ray, any comment on the breakaways?
Yeah, from a clinical standpoint, 24 to 36 hours, you're wanting to retorque those at 8" pounds. I don't know why, but torque drivers go missing. People take them. No, I'm going to make sure I have one next time I do a Halo. Well, they might not do one for 4 months. I can't remember where I put it. A great thing to have is the combination wrench and a couple 3 sets of breakaways in your desk from a doctor standpoint, or Masson's, I'm sure, has, items on hand. They're money. They're gold.
Yeah.
So you may want to just keep a little stash of those.
Just in case. Just a great resource. Yeah. Some other items that are available to make application that process a little bit easier. We do offer a Mayfield arm compatible bed adapter. So what you see here is 2 parts. We have the anterior and posterior of the surgical bed adapter. So you can order it in both parts as seen in the image. You can order just the posterior, you can order just the anterior, but it's designed to help with applying the halo ring or stabilizing the cervical spine during surgery using a halo ring. The surgical bed adapter internationally, we don't see it too much, but domestically, Ray, I think you've seen it in action a little bit more.
A lot. It's widely used here in the States. What's so great about it is the surgeons, if they're doing an anterior approach, you're going to use the longer piece. If they're doing a posterior approach, you're going to use the small L-shaped. And what it does is it hooks to the Mayfield arm, which is tucked under the surgical bed, and it applies directly to the center hole of the PMT ring. Instead of using the big Mayfield head box, they can use our ring to do a posterior or anterior approach with the Mayfield adapter, and it gives them a much more area of space to operate. When it's really an advantage is when they're reducing a fracture with the patient in our ring and bail. Then they go down to do the fusion. All they got to do is put the Mayfield attachment on it, and they go right into surgery instead of having to take the ring off and then put on the big Mayfield box and go into surgery. So these are some of the advantages, and we can answer questions at the end about that.
Another option that makes application easier is the head spoon and skate assembly. So the head spoon you can see in that top image, it aids in the positioning of the patient when you're applying that halo ring. So it holds the patient's place in head in place. So you can see this long piece of the spoon goes under the patient. And then this piece here, you see it's got a little bit of a curve to it. So it's designed to hold their head in place when it's extended past the edge of that surgical bed so that you can apply the halo ring while the patient is supine. And you can see the head spoon used with the skate assembly and a closed back ring here. So it gives you an idea of what that would look like with a patient. This allows for vertical adjustments of the head so that you can reach that optimal stabilization with that positioning there. This is, again, you can order them separately. So the head spoon can be ordered separate, or you can order the head spoon with the skate assembly. So both of those are available separate or together. Ray, with the head spoon skate assembly, any remarks on using that piece there?
Yeah, where it really comes in handy is when there's just one or two people doing a halo. You don't have as many hands. You don't have the help that you want. I mean, the doctor walks in the room with the chief resident. All the residents go scurrying to do a TLSO. They don't want to do a halo. So you may not have the help that you're expecting from your residents. But seriously, though, it's basically having 4 more hands in the room.
So these are some of those more unique components. I mentioned the pediatric angle blocks previously. So because of the small size of the vest, the angle blocks, they are almost always needed for a pediatric application, almost always. What you see here is an up close. So you see how the angle block screws into the ring. So this is what it looks like. You get a set of them and it screws into the ring, and then you apply your head blocks there. So you'll see what it does is instead of having the traditional angle like this, it provides a broader angle for the rods to be able to connect to that ring. With the pediatric angle blocks, these, if you are getting a pediatric vest, they are almost always something that you're going to want to have on hand. A similar option is going to be the kyphotic block. So if you have a patient that is kyphotic and is being placed into a halo, you can get a set of 2 of these. So this is what the size that they look like. And you can see what an adjustment it does when they're placed in those front chest blocks. So you can see it creates more of a drastic front angle where you are still going to be able to have that rigidity of the vest. You're still going to be able to have a solid placement of the ring, but it's taking into account their anatomy. So if you are dealing with a kyphotic patient, there are some other things that we might want to take into account. Maybe it's not going to be a perfect fit when it comes to our standard sizing. Maybe we need to evaluate doing a custom size for them. In that situation, we'll work with Massens and make sure we get that developed. But with the kyphotic patients, that is a option that we have available. Miss anything on that one, Ray?
No, that was very eloquently said.
Okay.
I would always, one thing I will add is when they're severely kyphotic, I would always go with the 1206-30, 33 head blocks, the longest head blocks that we have.
Yes. Yeah. All right. Talking about when we get that Halo system, when it gets to the actual application, you're going to take all the components out. You're going to get a manual with your Halo, and that's where these graphics come from. So your whole Halo system, when it comes down to it, you're going to have your Halo ring with those positioning pins and the head and the skull pins. You're going to have that vest with your liner. The vest comes with those 4 graphite rods already in the chest blocks. You're going to get your set of head blocks with the screws, the combination wrench, the pins, and then you're going to get those hex wrenches. You'll also have a traction bale if necessary. And then you'll have to order separately your torque drivers, or if you need some of those unique items like the pediatric angle blocks or the kyphotic blocks. So when you are looking at, okay, everything I need for the Halo, this is a really good snapshot, making sure that you have those pieces there. All right, Halo application. Ray, you want to walk us through this a little bit? I know you've been in on these, like you said, you've been in on hundreds of these. So
yeah,
I know you've gotten your fair bit of experience with what that can look like.
Yeah, so that's part of our job as reps in the U.S. We typically get there an hour early, prep the room. We'll go down to stock and grab the sizes that they need because we already know what the head circumference is, what the xiphoid circumference is, and we're dialed into what their needs are. So we will go down to their stock in the core, and we will pull the ring. We'll pull the sterile pins and the sterile positioning pins. We'll grab the wrenches. We'll have the combination wrench set. We'll even have a couple sets of breakaways just in case. But the doctors also have some of their unique items that they really like. And so instead of using our combination wrench, you might see like on that bottom tray there, that's a wrench that came from that facility. And that's okay. Just as long as it fits the locking nut size. And but as far as the torque drivers, you always want to utilize a torque driver that is in good calibration to make sure that we don't go through the table with the application of the skull pin. But you never want to open a sterile pack. You want to leave the things that are sterile in their pack. That set it off to the side, and they can do it in a clean or sterile environment. These things are done not only in the operating room. I've done them in the ER on a gurney. I've done them in the surgical ICU, bedside in a patient's room, just as long as it's a clean or sterile environment. Rules may be different in Australia, so I beg your pardon if I'm off kilter there. But that is a very good setup right there. Just everything laid out, ready to go. Take the head blocks out of the box. Have the vest assembly undone, have the posterior on the bottom, have the interior shell on top of it, the ring next to it, and then your components thereafter. It's a perfect setup.
Ray, would you like to take the lead on application?
Yeah, I'm not going to read right off the slide there, but
That's okay.
I'm going to go through it real time and without verbose. So the first thing you want to do is you want to get that ring attached because you've got somebody sitting there holding the patient's head still so they don't have an issue with their spinal cord with regard to their fracture. So you get the ring on first. Once that ring is on, and you want to set the skull pins in place to where they're all touching the skin. Once you get in that position, you go opposite. So if you're back front left, you want to go back right. You want to go front right, back left, and you go opposite all the way until they're all at 8 inch-pounds. Once that's the case, now the person who's at the head of the bed, keeping the patient stable, can use the ring to hold the patient in place. And you just want to make sure that you're doing opposite on the skull pins. Lots of folks, I will recommend, if you don't use the suction cups, I would get the suction cups. They're much better instead of the pads on the positioning pins. Sorry, Mackenzie, I do want to add 1 centimeter above the eyebrows and ears. That is the equator. You want that ring placed 1 centimeter above the eyebrows and ears. Thank you. Sorry. So here we see a patient that has, looks like the skate assembly and head spoon, and they're getting ready to go and do a halo. At this point, you want to put the vest on. The way I look at the Halo system is three subsystems. You have the ring system, you have the vest system, and you have the head block system. And so the second point is you want to get that vest put on at this point once the ring is attached. Barrel rolling the patient towards the person that has their chest towards the patient. It keeps them from having an issue of potentially slipping off the bed. But you tuck the posterior shell behind the patient, and then you roll them back on the posterior shell. Then you take the anterior shell and position it on the front of the patient. And the person that's doing the left side and the right side should be in sync. So on the waist buckle, you don't want it so tight where it would restrict their breathing. So if you can slide one hand in without it being very, very tight, that's what you're looking for. And if they're on the hole number 6 on the right side, you want to be 6 on the left. You want a very good symmetric fit to the vest. Again, it goes to the compression of the vest. That's the job of the vest. And then on the shoulders as well, you want to make sure that you're on the same number as the person on the other side. So if you're on 5, 5, 6, 6, and making sure it's a nice snug fit. You don't want it loose. You don't want it riding up on the patient. Once that's in place, you might want to forward. You can see that we want to now take the vest system, the ring system, and we want to join those two. And that's the head blocks. So you go ahead and attach the head blocks to the ring where it says head block attachment. There's a sticker actually that points to the 2 holes. There's 4 loose screws in this Halo system, not including the skull pins. There's 4 loose screws. That's the screws we're looking for. They come in the head block box. And so you're going to go ahead and attach those blocks to where they're snug, not completely torqued, because you want to use the movement of the head blocks back and forth on the ring to give you the angle to get those rods into the head block acrylic balls in the head block attachment. So once you have the rods connected to the blocks, then you can go ahead and position everything nicely and then tighten the blocks to the ring. Then you start from the head and move down. You don't want to have somebody on the downside trying to go up. You want to do it. That way you don't miss a single screw in the process. So go head down, and you want to torque those at 30 inch-pounds. And you'll be ready to go, and you guys can flash for an X-ray or do a scan.
Mm-hmm.
On this screen, it says 24 to 30 inch-pounds. It's 30 inch-pounds. You want to do 30 inch-pounds. The acrylic ball joints were tested over many years, and 30 inch-pounds is really where you want to go. You don't want to this is actually something I really don't mention very much, but I want to mention it here. If you do more than 30 inch-pounds, you could potentially crush the acrylic ball, or you could pierce it, and it may not be able to hold that rod in place. So be sure we're set at 30 inch-pounds, and you're ready to go.
That's a really good point. We don't see it too much, but it is possible. It is possible.
Oh, it happens.
Some additional considerations that we talked about briefly when we were discussing the selection of the ring. When you are working with pediatric patients, it is ultimately up to what the patient's anatomy is, but you may not want to go near the standard 8-inch per pound for the skull pins. Some situations warrant just finger tightening. You don't even pull out a torque driver. And the same goes for elderly patients because they also have those thinner skulls. Sometimes you do just go to the finger tightening. And so if you are doing a lower torque setting where it is under 6-inch per pound, we do recommend doing more pin sights in that situation. It creates a better and more secure placement of that ring. If you're doing, standard 8-inch per pound, 4 pin sights, 2 front, 2 back, that's the standard. But again, if you're doing a lower torque setting, you're going to want to think about, okay, maybe I should do the closed back ring. That'll give me some more pin sight options. And so if we feel that doing, say, 6 pins is going to be more warranted, you have the pin sights along that ring to be able to do that placement. Ray, any other comments on those additional unique considerations when it comes to that placement?
Yeah, look, it's the doctor's choice. They know the infrastructure of the patient, so to speak, and children and adults definitely. Most of the time in the U.S., they're doing finger tightening. Now, there's some doctors like, no, I'm going to go with the 4-inch pounds, which is what the default is in the United States. for kids unless it's an infant, and then they definitely do the finger tightening because their bone's not developed yet fully. So, but that was well said, Mackenzie. You're right on.
Thank you. So the other thing that is a part of our Halo systems, so with the Halo system, you'll not only receive the manual for yourself when it comes to walking you through the application, providing that technical information, but there's also a patient care guide for the Halo system. And this gives a little bit of insight into, okay, I'm wearing a halo. What does that look like? And it's also really, really useful when it comes to getting familiar and educating them as yourselves as professionals and sharing that information with them. Because there are some things that are just you're not gonna want to even try. We've seen it all. We've seen attempts at rock climbing with a halo. We've we've seen attempts driving and we understand the obvious patient frustration being in a halo. It is not an easy situation to be in, but if they are able to abide by these recommendations, it does make it easier. It's not going to be an easy process, but it can make it easier. So some of the topics covered in the patient care guide are lifestyle. So when it comes to wearing a halo vest, you're going to want to wear clothing over the vest, and it should be loose fitting. You can wear, it is recommended to wear maybe a cotton shirt or a tank top underneath the vest. And that would be if you're starting to see maybe some sort of a rash or broken skin. A very rare situation, but if there is a lamb's wool allergy, go with the Cool Max liner. That's an option. When it comes to just general mobility, if you have a caregiver, make sure that they are not grabbing the rods and using them to lift or turn or navigate the patient. The other thing to keep in mind with that is as they wear the halo, as they're moving in that halo, even though it is a rigid fit, they may need to have some adjustments throughout the course of treatment. And that loops in the pediatric remark that Ray pointed out. Those kids are growing so much faster. So it's important to make sure that, if you are noticing that they are growing, we might have to look at making an adjustment to their system. Most of them you're able to resume daily activities, but you need to allow for the proper recovery time. So the day you get a halo applied, you're not going to be out taking a walk. You're going to need to give your body a little bit of time. To that end, again, they should not be driving, riding a motorbike, bicycle, new thing, scooters. Don't get on a scooter. And then the other piece of this when it comes to sleeping, it can be difficult to get comfortable while you're sleeping, but you don't want to place a pillow between the rods and the patient's neck. So placing a pillow almost like snaking between the system is actually going to be a disadvantage towards their healing process. Before I get into hygiene, which is a really, really big talking point for any halo patient, Ray, any other advice or things that you've seen when it comes to lifestyle patients wearing a halo?
I mean, Mackenzie, you pointed out everything other than the movie Bleed for this, and start weightlifting and trying to, train for a boxing. There's a good movie out there that shows the PMT Halo very vividly, and they actually show a removal and an application. If you haven't seen that, I would definitely see it. But yeah, they need to take it easy for 3 months.
Mm-hmm.
And with regard to sleeping, unless you have a bed that is like a hospital bed where you can get them up on an angle like this, I hear from almost every experience that I've been involved in with people with Halo is they're in a lazy boy. They're in a lazy boy, and that's just all there is to it. And they think, okay, well, I want to be comfortable. I want my head on a pillow. your head suspended. It's not, the pillow's not gonna, you're suspended. It's a mental thing that they want a pillow. It's that it is not good. But a recliner, a lazy boy, is something that we've heard that is probably the best for sleeping.
Yeah. And so honestly, probably one of the number one talking points that you're going to get when it comes to the patients, it's hygiene. Okay, if I can't take this off, how do I take care of myself? The Halo vest, it needs to stay clean and it needs to stay dry. So to that end, when we talked about being able to swap liners out, that is an option. But you're not going to be able to get in a full shower. You're not going to be able to do that. Bathing is going to be done via a sponge bath. So as far as body, you're looking at doing it outside of the standard, standing in a shower. And you don't want to use those soaps or lotions or any kind of product on the skin underneath the vest. That can end up not getting fully cleaned. And then the material of the vest holds that in. So we recommend when you're cleaning under the liner and under the vest, use a antiseptic alcohol and mix that with a little bit of water. And then one of the most difficult pieces of it is washing your hair. And we've seen some really creative options and ways that people have tried this. I know Ray's, seen people go outside and put their head over a large trash can and, you can wash your hair, but the pin sites need to be healed and they cannot be infected. So these can't be brand new wounds. If you're doing hair washing, first of all, you're going to need someone to help you. The patient isn't going to be able to do this on their own. This is going to need to be a buddy system situation. So they should be done when they are supine and their head is over some sort of a catch basin. So whatever creativity that entails, you'll want to make sure that you're also just being really, really careful. So whoever is the caregiver or going through this process with the patient, you'll want to make sure that we're being very cautious, making sure that the water doesn't get, drip down the patient's head and into the liner, because then again, that moisture is going to sit there, right? When it comes to the pin sites, this is a really, really important one. So they do need to be cleaned daily, and it should be done with a mild soap and water or a hydrogen peroxide and water solution. And then you need to massage those sites. So with regard to the application of the pins, a lot of the placement when it's done, they'll make almost a little X incision so that when they're twisting those pins into the skull, it's not taking the skin with it. So by making a little incision when it comes to the application of the pins, that can make it easier. But no matter what, you want to be very, very cautious of that pin site. So whoever is wearing the halo, the patient, whoever's the caregiver, it's really important to continually monitor what those pin sites look like, because if they are not taken care of appropriately, if they're not monitored, that can lead to an infection at the pin site. Ray, again, you have seen some very unique ways to take care of hygiene that have worked, but anything else regarding hygiene, taking care of ourselves during that halo process?
No, you covered them all. One thing, keeping the vest dry. A lot of folks just will use a shower curtain and literally just completely wrap the patient from the rods around here up to the top, and they'll find a chair that they're above the backing, and they'll put a garbage can down, and they'll use a flower pot, a watering pot for flowers to wet their hair, and they'll use shampoo and then rinse. And then that's one time a week. The other 2 times a week that they do it, they'll use dry shampoo. Other than that, you nailed it.
Awesome. So some other things to keep in mind, complications, things can happen. If you're wearing anything, let alone a Halo vest, things can happen while you're moving around in it. So it's something that can happen. The pins can get loose. And if that's the case, the patient should immediately let their provider know, because then the skull pins are going to need to be retorqued to their setting. So a way to prevent this right away, after you place the halo, after about 24 to 48 hours, you're going to want to have the patient come in, and you're going to want to do a initial retorquing of those pins. That's just that initial wear, things can happen. But by doing a follow-up within, that 24, 48 hours, a day or two, that can help. And then making sure that before you retorque those pins, make sure that you loosen those locking nuts. So around the pin, you have the locking nut that sits against the ring. You want to make sure that's loosened before you retorque. And then once you've retorqued, you again retighten that with the wrench. With the pins being loose or moving, Ray, anything on that or any other?
If you have a patient that has loose skull pins after the 24 to 36 hours of retightening, they're not a compliant patient. It's just not going to happen. They're doing something extraordinary out, getting on a motorcycle, climbing a hill, whatever it is. They're not going to have a pin come loose unless they're non-compliant. And so beware of that. And we always have the wrench set and the 2 Allen wrenches that really for emergency removal. We always used to say, tape them to the front of the vest. We don't do that anymore because patients would just take off their halo and walk to their doctor's office and go, here, I don't want this anymore. And so we've now said, tape it to the back of the vest so they can't see it. Also, one other thing about skull pins, the black caps that go on the skull pins when we ship them to you guys, once the halo pins are in place, particularly the interior skull pins, put the black cap on the outside so they can't see that there's a wrench that can unloosen them. Very important to do that. I know that's a small thing, but it'll alleviate the patient looking in the mirror going, hey, that's a regular 3/10 Allen wrench. I can get this thing off. And you just don't know. And it does happen. So those are some other things that you might want to consider and use your best practices.
And when it comes to the pin sites again, this is where they need to be really, really careful if it becomes infected and antibiotics and cleaning aren't clearing that infection. First of all, they need to be very well educated. They need to, take care of themselves and watch. It's going to be fairly clear if a infection or a reaction is developing. So they need to just monitor what that looks like. If they don't take care of it, if they aren't cleaning it, then it's gonna be just a matter of time. So they need to monitor that. Now, in the situation where when they're cleaning it, making sure that they're using that mild soap and water, that hydrogen peroxide water solution. They're also going to want to massage around the pin sites and push the skin away. And then make sure that they are removing any sort of debris away from that pin site. So making sure, okay, if I have skin cells there, I'm moving that as I'm cleaning. I'm not just doing kind of that. We all kind of know when it's, okay, I just did a once over. They want to make sure that they're being very mindful of how they're taking care of those pin sites. Now, if something happens where, again, that infection gets to a point where, they did not catch it in time, you can move the head pins to alternate sites. Not a commonality necessarily, but it does happen. And so in that situation, you can move the to a different pin site. So if you're looking at the ring here, say I've got my pin here, I can move my pin from this hole to a separate hole there. Ray, I have not encountered that, but I know you have. Any insight into, navigating, moving that to a different site?
Yeah, and it's going to depend on the patient's age and other things that go into it. The doctor's going to make those decisions. If they're not old enough to have that muscle more inferior to the second hole on the ring from the center. So 1, 2 is your typical one. If their muscle's not intact yet, and they're going to move to the third hole, but that is the doctor's decision. That would not be something I would make from an orthotist position, or certainly a rep situation.
And one of the other, there are other complications, but one that can occur is a pressure sore situation. So you'll want to make sure that in order to prevent these, if it's a bedridden or sedentary patient, they need to be repositioned every few hours. So this is where, if it's a bedridden or sedentary patient, this is where reminding that healthcare or that the caregiver with the patient, do not grab the rods to move the patient. So these should not be used as a form of handle situation. You'll want to reposition them. You'll want to keep their vest liner clean and dry. And you can alleviate pressure a little bit if they, placing a pillow, not by the ring in between the rods. But the other thing is monitor the skin under the vest. So if you do start to see the development of a rash or a skin condition, change the liner, dress the sore, and then you'll want to have them wear as mentioned previously, a cotton light t-shirt, tank top between their skin and that vest. So again, these are not common, but if we're talking about complications, these are the common ones that we see. Some other things that can occur but are rare. You can have a skin rash, as I mentioned, from an allergy, or you're not cleaning it properly, right? If you're letting soap get between that liner and your skin. If you damage your vest, again, as we mentioned, if you're trying to maintain a really, really active lifestyle, you can cause damage to your vest. You can cause damage to your whole halo system. And that's going to compromise the traction of the whole system. So if they are doing something where, again, very rare, but if they are doing something so advantageous as to, say, crack their vest shell, okay, we've got a compromised entire situation here. My entire fixation is completely, you need to replace it. Another thing that can happen is during application, you can damage or puncture the skull plate due to high impact force on the pins or improper torquing. So that can happen on a day-to-day basis. It can also happen during application, retorquing. Again, that's where being very mindful of using the appropriate pounds per square inch on those pins, and making sure that when you're wearing a halo, making sure the patient is aware, I'm not just my own skull anymore. I have something that is around me and is going to take up a little bit more space. So not only are they having the ring that comes out from their skull, but the pins come out further. So being mindful and having that spatial awareness as those first few days and weeks happen, making sure that we're not bumping into things. And it sounds very simple, but these things can happen where all of a sudden, you turn around and you hit that pin, and it's that easy. So, Ray, other complications or things that you wanted to touch on at all regarding the halo and what can go not wrong, but what can cause a little bit of you have to pivot and adjust how you approach it.
No, you very well said. There's a reason why we call it a rigid mobile asphyxiator. we kind of want them to have some movement. I hate to hear bedridden or, you know, they're just, you know, sitting there around. They should have someone with them and take them for a walk and guide them outside and be somewhat active.
Mm-hmm.
But tender loving care needs to go along with that. And
Mm-hmm.
they really shouldn't do anything that's going to cause an issue for whether it's the skull pins or the vest. It should not be doing it. And
Mm-hmm.
the way you get that through their head is, hey, you know, you fall, you have a fractured cervical vertebrae. If you fall and that vertebrae hits your spinal cord, you're quad. I mean, why put the risk out there,
Mm-hmm.
you know, to be, you know, kind of wild and crazy and maintain your lifestyle while you're in this thing. So, um, I think consulting the patient initially, once the halo is applied, goes a long way, and I
Mm-hmm.
think that I think that'll lend itself to a very good conclusion and outcome
Mm-hmm.
with a halo patient. So
Ray, do you briefly want to go through the halo removal process?
yes. So um, the first thing that you want to do before a halo is removed is put the patient in a cervical collar that's fitting to the patient. They are going to have their ligaments and their tendons are going to be atrophied. Their muscles are not going to be able to carry the weight of 8 pounds. So the first thing you want to do is put them in a collar before anything is done. The removal of the vest would be first. You want to have a patient on either side of the patient, helping them stay, you know, still and support their weight. Once you have that done, you go ahead and take off the blocks, the head blocks, and then you want to go ahead and remove the ring. They're going to go ahead and put in some lidocaine before they remove those skull pins, because they will have capsular contracture and they will meld. The threads will be ingrained into the bone, and it is painful. And so they'll definitely want to put some lidocaine in there. Just like the application, opposite. So if you start with front right, go back left, and so on until you have each one completely loose, and then they can be removed independently of where they are in the patient's head. Once that's the case, slowly 2 people bring them to their feet and hold and stay with them until they get their balance and they get their bearings, because they just haven't had the weight in the 3-month period. And then the doctor will give them the direction and so on to make sure they're treating their skull pin sites appropriately.
Mm-hmm. Perfect.
Yeah, thank you both, Mackenzie and Ray, for that informative and, of course, eloquent presentation, as Ray put it. Starting with Shane's question regarding calibration of the torque wrench and its frequency of use.
Yes, unfortunately, frequency of use does not play into the calibration date. So due to the design of the torque driver, the tension that is in that product, even if you only use that driver, say, once a year, the calibration does not extend. It's based on the lifetime of the year. So in that situation, you know, make sure that you are monitoring those. When we dispatch torque drivers, we do dispatch them with as much time as possible with that year. So
the
hopefully
reason for that is, I don't mean to interrupt you, Mackenzie, but I want
them
to
for
understand, because that's what's in the
right.
makeup of the gearbox inside that torque driver. And the spring only will stay at its tension for 1 year. And that's not our design. We take all the raw materials and build that. And that is the best we can do with regard to the tension of the spring, was 1 year.
Jocelyn, I see a question from you. What is the retention protocol? I am not completely sure in what context or what point in the presentation that came up.
So this is Bill, Mackenzie. I think that may refer to the retensioning of the pins. retentioning of the skull pins in terms of that 24 to 36 hour
Yes,
retentioning protocol.
Sure.
I mean, look, there's going to be patients that live, you know, a day's drive away. If they can't get there exactly, it needs to be sooner than later. Because there's going to be movement. They're going to be restless. The reason why it's 24 to 36 hours is they think they're not moving, but they're moving, and they're putting some pressure on there. And so we want to get that done within 24 to 36 hours to make sure they are fully fixated. And once that's in place, we're good. But if it's 48 hours, it's 48 hours. We just need to make sure they get retorqued.
Yep. Gavin, question regarding have you seen any difference in infection or loosening rates between the titanium and ceramic pins? We cannot, unfortunately, speak to the frequency of infection or loosening pins with the ceramic. PMT never offered a ceramic option, so we can't totally speak to that. As far as the infection or loosening rates go, it's not common. In relation to this, kind of ties into Carly's question as far as data, pin loosening or pin infection. PMT does not keep data on that. That is going to be considered something that is monitored by the facility, by the healthcare provider. So if there is ever a situation where it is a true adverse event, then that goes through the proper reporting protocol. But as far as the pin complications, we don't keep data on that. Ray, I don't know if you have anything else to bring up on that.
They could Google white paper regarding Halo skull pin Halo loosened skull pins, or it's some vernacular, however they want to put it in Google, and they may find a white paper that shows some data on that. And certainly they can do that research as well.
Perfect. Ling, I see you have a question on the how to approach the vest selection for an adult patient with pectus carinatum or extreme bony sternum and ribs presentation. So this is going to be one of those really unique patient situations where what we've done in the past is depending on the severity, we may want to evaluate a custom vest. We've done custom vests before where if we can get some photos and really distinct measurements, what we're able to do is actually design a vest where maybe it has a little of a bump to accommodate that. And so we've done that before. I had one maybe 2-3 years ago. So that's an option. It does take a lot of really intense communication. We're going to ask you for so many pictures, so many measurements. But because of our abilities here in-house to generate the vest, we can do it in a way that might adapt to that patient. So I've seen it once in my time, but Ray, I'm sure you've seen it a little bit more than that.
Yeah, we can accommodate that issue. We'll like Mackenzie said, a couple of pictures, some increased number of measurements, the overall circumference of the defect, and Mark Segner is a whiz doing these, and he can get that done, no problem.
More pin questions. Again, I would recommend, there are some third-party studies that those can be looked at. As far as what we monitor, we don't have that. However, when it comes to complications with loose pins, when you do retorque those, even if it's outside of the 24-48-hour window, as far as the tools go, correct me if I'm wrong, Ray, maybe there's a little bit of a different, use process with this, but you'll use the same tools. You'll use your torque drivers. And so what you'll want to know is just, okay, when I had the patient in for their first application, we torqued the pins to this torque setting. When they came back, we retorqued them. They were a little loose, but that was it. So when you're doing those retorques, it is going to be the same tools. Ray, I don't know if there's anything else unique that you want to mention on that outside of that initial retorquing window.
Nope, just a reminder that you very well said, make sure you have the combination wrench, loosen that locking nut before you retorque, then make sure you fully tighten that locking nut after the retorquing.
And Ashley, I know you mentioned, you asked, how are we measuring loose pins? Loose pins, you're going to detect it in a few different ways. The first way is going to be that patient sensation. They might be able to tell you really quick, something does not feel, obviously I've got a halo on, this is not normal, but something really feels weird. Okay, let's have you come in, let's loosen that locking nut, and if you torque it to the setting it was at and you had a little bit of that give, okay, yep, hey, that right pin, that one was a little loose. Okay, to walk me through your daily activities so I can try and, guide you on, okay, maybe we don't go for as long of a walk, right? So things that you can do to adjust that lifestyle to minimize the chance of that happening again. But the reality is, as Ray mentioned, even with it being a rigid external fixation, you're still up and walking, you can still move. So some loosening can happen. But the other way that you'll notice that is just during those regular checkups. Ray, as far as the sensation goes with that, any particular adjectives or things that we should be mindful of that get feedback?
It'll feel unstable. It'll feel like that they're just not stable, and the patient will know more than anybody which one it is, because they'll feel it, because they've been so rigidly stable, and all of a sudden they're like, wait a second, I don't feel confident back in my back right. And and really, if you're going to see the patient, there's no harm in retorquing to 8-inch pounds when you see them. There's no harm in that. So they just might be a little bit more active. They may be bending down and picking up dishes. They could. It just depends on the amount of activity. It can happen.
I think I covered all the questions that I saw. Bill and Phil got to a lot of the questions outside of product. All right, Ashley had a question follow up here, Ray. Is there an objective measure of the loose pins?
Okay. Objective measure. What I think of when I hear that is you use your fingers and see if it's loose at all. I'm kind of I don't know what that really means. The objective measure. Really, the only tool that's going to be sure that it's 8-inch pounds is the torque driver. And I don't know how else to put that. Patient sensing that it's loose, and that could be psychological. So it's err on the side of caution, retorque it at 8, relock the locking bolt after, and you're good. Should be fine.
Perfect. All right.
Yeah, I think that's covered all the questions.
I think we got everything. Yeah.
Sorry, Bill. Sorry to go over, Bill. We just want to make sure it's very thorough.
No, that's okay. It's all good information, and we all appreciate your time presenting this webinar, especially late in your day during the winter over there in North America.
No problem. No problem.
This is what we do, so we're glad to do it. It's not a big deal.
But yeah, thank you, Ray and Mackenzie, and for all the attendees, reach out with any further questions to any of the Masson's team. We're here, throughout the days to respond to those questions and help you out further page. So thank you all and enjoy the rest of the day.
Thank you, everyone.
You guys have a great day over there.
Thank you, Ray. Thank you, Mackenzie.
Bye.
See you soon, Bill. Take care.
Okay.
Bye, McKinney.